Welcome, everyone, and welcome, Veena. So I'm going to begin with a land acknowledgement before I introduce our esteemed speaker. So I don't always do land acknowledgements for reasons that I'll get into, but I'll start with one because that is the tradition here. So as this is a hybrid event, some participants are on different territories. So please take time and space to give thanks and gratitude and respect to the land you're currently living and working on, wherever you are. So today I'm here at York University campus in Toronto, which is situated on the traditional territorial area known as Tkaronto, and we acknowledge its current treaty holders, the Mississaugas of the Credit First Nation. We also acknowledge that this is the traditional territory of many Indigenous nations, including the Anishinaabe Nation, the Haudenosaunee Confederacy, the Huron-Wendat, and the Métis. This territory is subject to the Dish with One Spoon Wampum Belt Covenant, an agreement to peaceably share and care for the Great Lakes region. The reason I don't always love doing land acknowledgements is because I feel like they've become a bit of a box that we check. So I thought it's also worth just noting that 2 days ago, the Mississaugas of the Credit First Nation received a preliminary payout of $30 million in recognition they were absolutely scammed out of their land in the Mississaugas of the Credit River. They no longer even live on the Credit River, where they had historically fished and used the land for thousands and thousands of years. They've now shifted to a reserve kind of below Hamilton. And what had happened is they made a treaty 22 and 23, with the colonizing government saying that this land would be available for them to continue using. So it would be shared use land, and they would be able to continue fishing. And the government just sold it right out from under them. And my dad grew up in that area, and those properties are now worth millions. And they got their first payout of $30 million to recognize that that land was taken from them unfairly. It's just the beginning of a financial reckoning, but you'll never get back the generations of displacement. So land acknowledgements, yes, but reconciliation more so, right? So let's now change gears and welcome our speaker for today, Dr. Veena Sriram, who is one of my dearest friends and a colleague, and also somebody I went through my PhD with long back. So just incredibly honored that she was available and agreed to speak to us today. So Dr. Sriram is an assistant professor and Canada Research Chair in Global Health Policy, with an appointment at the School of Public Policy and Global Affairs and the School of Population and Public Health at the University of British Columbia. Her research sits at the intersection of global health, social science, and public policy, and her interests are in understanding power and politics in the policy processes, primarily in low and middle income countries. She draws upon theory and methodologies from the social sciences in conducting her research, and has a particular focus on qualitative approaches, although one of the readings you guys had today was a quantitative one that she's also been involved in. And she's published widely in all the top journals, so she's amazing. She has a particular focus on health workforce policy and health sector governance, as you're going to see today, and has conducted extensive research at the national and state level in India in particular, looking at health policy and systems questions around medical specialization, emergency medical care, national health authorities, and health workforce policy development. Dr. Sriram has received funding from the CIHR, SHRC, and has received fellowships from the American Institute of Indian Studies and the U.S. Fulbright program. She's a graduate from Johns Hopkins University for her PhD, as well as a Master's of Public Health from Columbia University and a postdoctoral fellowship from University of Chicago. So it's my absolute honor to welcome Dr. Sriram and turn the floor to her.
Wonderful. Thank you so much, Carrie. Can you all hear me? Is this coming through? Okay.
Perfect. Yeah.
Yeah. Awesome. Well, lovely. Thank you so much, Carrie, for that really generous, kind introduction. It's such a pleasure to be here with all of you. It's great to meet the community at York, and thank you to you, Carrie. Thank you, Natalie, and thank you for the team for putting this together. Just wanted to say, Kerry is someone I hold very dear and have learned so much from her, continue to learn so much from her. She's one of our brightest spots in global health, and yes, I'm just really grateful to be here with you, Kerry, and with all of you. So um, on to our topic. So let me just briefly introduce what I'll be speaking to you about today. I'm going to be talking to you about some new work, or should I say, um, an attempt to put together a series of projects in a new way, I should say, on health worker protests during and beyond COVID. And as Kerry mentioned, I'm at the University of British Columbia, and just want to acknowledge that our campus and where I am located right now is on the traditional, ancestral, and importantly, unceded territory of the Musqueam people, and also want to recognize the Coast Salish peoples of the region, and appreciated the context that you provided, Kerry, earlier. I think the piece around these territories being unceded is key for us to sort of reconcile with. So thank you again for inviting those around to also share to share reflections on where they are currently located. So in terms of an outline for the talk today, I'll be speaking to you about some studies that we have done on health worker protests in the COVID era. And I'm going to put together different studies and kind of try and draw out some themes about what we can understand from looking at health worker protests about the health systems that we work in and the health systems that we study. What does it tell us about the issues and challenges that we face? So I'll be talking to you about some of the kind of analyses we've done on health worker protest trends and patterns, and then dive a little bit more deeply into some geographic foci, particularly Canada, and also looking at some professional groups like trainees. And then in the second half, I'll be talking about some case study work that we've been doing, and that's very much ongoing, I should say, that's trying to delve a bit deeper into specific examples of protests and put that into context around union politics and association politics and health governance. And then really looking forward to having a Q&A with all of you. I should mention, just to kind of set it up at the top, that as Kerry mentioned, I'm a public health person by training, but have drawn on the social sciences as I've gone along. So just want to give you a sense of my disciplinary background, and to also mention that this is very much the work of a collective. I'm putting together studies that I've done with colleagues over several years, and although they cannot be here, just want to acknowledge their immense work in doing this. In many cases, they have driven this work. So I'll acknowledge them towards the end of the presentation by name. Okay, is this coming through? Yes, there we go. So I want us to rewind about 5 years now. And if we go back to the spring of 2020, I'm sure many of you across different contexts were probably seeing very similar things in terms of the protests from health workers regarding their work during COVID. So scenes like this were extremely common across the world, and certainly here in Canada and to our neighbors to the south. But also this one picture on the right is from Pakistan. Again, this was happening globally. So health workers were really in the eye of the storm during COVID, and very early on, within days and weeks of the pandemic materializing, we could see that health workers were being faced with extraordinary pressure, but in the face of considerable uncertainty. So they began to vocalize a range of concerns, such as those that are listed here: very high workloads, burnout, um, the lack of PPE, which was the focus of the protest in the previous slide, workplace protections, violence and assault, even death of health workers. But it's very important to recognize that health workers, the protests that they were conducting were in the context of broader systemic challenges. So in policy decisions and investment decisions that were taken over years regarding staffing, regarding privatization of services, all of these decisions created the context in which health workers were then having to really perform at an extraordinary high level with very limited resources. So some colleagues and I, specifically Sorsha Brophy, who is currently at Columbia University, and some wonderful graduate students at the University of Chicago, at UBC, and also I want to recognize colleagues at the Accountability Research Center at American University. We all came together to try and think through, okay, what exactly is happening around health worker protests in this period of time, and we decided to look at 2020 to 2021. We started this work in 2022, early 2022. Actually, a few months before that, but we kind of finalized the analysis in 2022. And we found that there were about 6,600 protests by health workers using a database called ACLED, which is the Armed Conflict Location and Event Database. It initially started as a database focused on political violence, and over the years has expanded to have many different categories. I would strongly recommend those of you interested in these types of data to take a look at it. At the time, we looked at 149 countries, although right now they've actually expanded worldwide. We looked at the distribution of protests geographically and also temporally. Much harder to look at types of health workers, interestingly enough, and I'll share a little bit more about that later. And then we looked at protest demands made by health workers, and the findings are in this brief. So again, we looked at the first official year of the pandemic, 2020 to 2021, and what did we find? Some high-level observations are that health workers engaged in protest activity with a greater frequency during that year compared to the previous year. There was 85 countries in common. ACLED has gone on a program of expanding their geographic data set rather over these last actually 10 years. And so they added on about 60 new countries in 2021. So we had 85 countries to look at in comparison, and there was a 62% increase in those countries. By far, the largest category of protests were those concerning working conditions and remuneration. How do we know this? Well, each event in ACLED has a very short summary, just a couple of lines, but it tells you what the protest was about as best as the researchers collecting that data can pull together from their sources, that is media, social media reports, and so on. And so it was about 66%, overwhelmingly about working conditions and remuneration. Very interestingly, PPE, which was the focus of so much media attention, was actually a relatively low percentage of protests, only about 9%. And the vast majority of protests around public policy issues concerned pandemic-related policy. So issues such as climate change, immigration, police brutality. Remember, this was the year of the George Floyd protests and also elections. And this chart kind of lays it out. It's going to be really difficult to see it, I know. So I'm just going to kind of maybe give you a couple of quick highlights. Again, working conditions were 66%. I just want to give you some examples of what these looked like. It looked like unpaid wages. This is very common, for example, with cadres that we see in India, like community health workers or contractual workers who are just not paid salaries for months on end. Risk allowances, job security. Why this is important is that it really complicates this narrative of health workers as heroes. I think many of us remember how health workers were valorized at that point in time. But it's clear that their rights as workers were not being given the same attention. And the support and protections and security to do that job. And the frustrations were also quite generalized, beyond even working conditions. For example, issues such as not having, for example, students and trainees during that period of time running into all kinds of problems with their institutions in the health sector around accessing course materials, examinations, program fees, stipends, and so on. The second issue was around health system delivery. So that's the second bar. And that concerns health system investments, quality of services, distribution of access, and so on. And also just want to kind of note that there were a small number of protests. The last one there was around solidarity with other workers and also just demanding recognition from their employers. So we did this research and we started to get questions about, well, 85 countries as a comparison's not a really, it doesn't really tell us as much as we need to know about trends. Can we do a little bit more of a rigorous analysis to understand these patterns going back a couple of years and then going forward into 2022? So we decided to do that research through a grant that we got from SHIRK that allowed us to kind of have a longer term study that produced models on two main outcomes. The first is the number of weekly health worker protests between 2018 and 2022 and the number of countries with one or more protests in a given week. So it's not just the volume, because you can imagine that there might be countries like India with enormous protest activity that might be accounting for a lot of this. So we wanted to look at country activity as an additional outcome. So what we found was that there were 18,322 health worker protests in 133 countries between 2018 and 2022. The number of health worker protests increased, weekly health worker protests increased by 47% post the onset of COVID. And the number of countries experiencing that protest, so this is this chart on the right, this increased by 24% following the pandemic sort of formal declaration in 2020. So you can imagine that, when we think about this vast data set, there are so many different directions that we can go in. So, we understand that there's this global increase in protests, but you can do further analyses in a few areas. You can go to specific countries. You can look at particular groups of health workers by seniority, say. You could look at particular occupations. So I'm going to present some data to you that looks at one country, the country we're in right now, Canada, and I'm going to share some data about some work we've done on trainees. So starting with Canada, we looked at all the data in ACLED around Canadian health worker protests. And we found about 157 between January of 2021 and December of 2022. 157. Ontario had the highest number of unique events with about 63 events within this time frame, and Quebec and BC followed with 25 in each province, and Alberta followed that with 18. So I want to share a couple of points here to kind of underscore why this kind of country level analysis is really important. The first is that I think it tells us about what is motivating health workers and what's the current set of debates that are taking place in a particular context. We can get some of that by looking at these protest demands. If we go back a couple of slides, we can see that health workers are really not just concerned with their own working conditions. They're asking bigger questions about the type of health system that they're working in, who's it serving, who is it not serving, right? Especially in that health system delivery category. In Canada, similarly, we did see that the majority of events did concern working conditions and compensation primarily. But there were some very interesting clusters that we found. This map, I know, is not ideal to be able to read, but maybe I'll just kind of talk you through some of the clusters that we found. So we found one cluster of activity in September 2021 that was part of what's called a worldwide walkout for health freedom. And this included 12 protests in 4 provinces organized by the Canadian Frontline Nurses Network. Now, this is really important to note. This group was focused on advocacy against COVID-19 mitigation, right? So they were protesting against vaccine mandates, against mandatory masking. I want to make it very clear that this is not the majority of protests at all. These are just clusters of activities that we found. the vast majority of protests concerned working conditions, improvements in compensation. And so that is where the majority of the Canadian health workforce is. But you do see these clusters, like the one I just described, that were working against, that were, I should say, protesting against mitigation measures that the public health community was advocating for. A similar cluster took place in September 13th, 2021. Protesters demonstrated against the COVID-19 lockdowns in about 13 cities across 8 provinces. This is really important. And you could see kind of the expansion taking place, again, organized by the Canadian Frontline Nurses Group. Why I think this is important is that I think it's a signal regarding the current state that we seem to be in public health and in society more broadly, in terms of this kind of pitting of personal freedoms and collective action. And we see the starkest example of that is what's happening in the States right now. So just wanted to say that, this is not this is happening in our borders as well, and there's evidence of that in some of the protest activity that we see. A more positive story, at least from my standpoint, is what happened in Ontario, December 12th, 2022. Across Ontario, there were protesters demonstrating against how leaders at the time were handling the introduction of Bill 124. There was about a network of 400 grassroots organizations organized with the Ontario Health Coalition that organized protests in support of progressive health policy across the province, specifically with Bill 124 as kind of the center of that. Moving on now to so we've talked about, what we can understand by looking at a specific country and what that tells you about the direction of health policy in that context, or the state of health systems in that context. Now, let's move to understanding actions by a particular category of health workers. In this case, we're going to talk about trainees in the health profession. The previous work that I described is the paper is about to be published in a couple of weeks. But this work that I'm going to share is very much in progress, and representing a team that I've noted below. We looked at, between 2021 and 24, all the protest activities by trainees. And why did we pick trainees? So there are a couple of reasons here. The first is that, if you all recall, during COVID, during the sort of the kind of key phases of the pandemic, years 1, 2, 3, trainees were often called into providing a lot of that urgent, acute care that was needed. In many cases, it happened sort of at the expense of their education. They were sort of called in because it was an emergency situation. But then we also started to see evidence of trainees protesting around the world. We started to see examples in the media. So, for example, what happened with the junior doctors in the UK, what happened with medical students protesting enrollment increases in South Korea. You all may recall last year in India, there was a horrific assault, rape, and murder of a resident doctor in Kolkata that resulted in hundreds of protests in India by resident doctors and trainees. So we wanted to kind of understand this bigger picture, and we looked at ACLED again to see what we could find. And we found about 800 plus events involving just trainees from 65 countries. The majority of these protests were in India, 219, followed by Nepal, and then the United Kingdom, and then South Korea. I want to be very clear also that this was till April of 2024. So this does not include actually all the protests that happened in August of that year around the rape and assault and murder of the resident in Kolkata. So you can imagine what this chart might look like, the one on the left, if we were to include that. It's already at the highest level. It would be exponentially more if we included that data. So what we can also see from this figure, in addition to this being a very globalized situation, we can also see that the majority of protests in the chart on the right are organized by medical students, followed by residents, followed by an undefined category of health workers. This is the challenge with ACLED, and then nursing students. And then you have the other categories. So clearly medicine is dominant here. And we're doing some analytic work to understand, what is it in the medical profession that gives medical students the ability to, or the protections to protest when you see less of that in other in other professions. So I'm just going to take a quick sip of water. Okay. So across the 118 protests, financial compensation was by far the largest concern, 218. Again, this includes negotiated increases to their stipends and their wages, yes, but it also includes missing stipends, missing wages, those sorts of things. We then have issues related to the quality of the training program, such as infrastructure that's missing or dilapidated or just not kept up. That's about 110. Working conditions were about 92, violence against health workers 48, and really interestingly, protests against war, violence, and social unrest were 48 protests. I'm just going to give you a couple of examples here just to paint a bit of a picture of what's going on. There's so much to say here, and I'd love to kind of unpack it with you in the Q&A, but just a couple of examples. Compensation, an example that you may have heard of is protests in the United States by residents asking for higher pay and for stronger protections. And this happened, this should also we have to zoom out and think about the context. You rarely see doctors protest and strike, and you see them protest, but to some extent, but you rarely see them strike. There's a kind of code of ethics around it. And in this case, the resident doctors decided, nope, we have to do this. So let's kind of move now to a different continent. In India, resident doctors protested against the system of examinations for postgraduate training. This may seem so, confusing, but really what they're protesting is the system by which they are allowed to enter into residency programs and a lot of the dysfunction around that program, and widespread protests about this. In Pakistan, our neighboring country, students were protesting the implementation of a licensing exam that would be mandatory for all students graduating, and said that how can you have a licensing exam when the infrastructures in which we're studying are so under-resourced? And you can't suddenly kind of expect us to deliver on an exam like this when the quality of education has not been up to the mark. So a lot of interesting debates about that. And then moving over to the next neighboring country, Afghanistan, medical students were protesting the fact that the Taliban had decided to ban higher education for women. So there was widespread protests in this one university in Jalalabad against that. You saw protests in Turkey, Italy, many countries around what was happening in Palestine, in Ukraine, and then lots of other examples that we can chat through in the Q&A. I'm just conscious about time. So zooming out now, okay, let's take a breath. That's a lot of information. Our analyses reveal the extent of protests and the overarching demands that are expressed. We have a sense now that, yes, protests are happening. They're happening globally. They're happening more frequently. And health workers are clearly frustrated about so many aspects of their rights as workers, but that they're also protesting about these larger policy issues. What's less clear, though, from this analysis is, what is the role of protest as part of a broader set of advocacy strategies? What does the use of protest reveal about professional identity? What protests are covered in the media and what's left out? And how does protest actually ultimately impact outcomes? And, there's lots of interesting public policy frameworks to help us think this through, but I have found one of the most useful to be from Weibel and Heikila, this idea of a policy conflict framework that helps us look at these episodes of policy conflict and put, protest into conversation with those other factors, like the institutions and the setting, but also the types of actors involved, and ultimately, the outputs and outcomes. I'm going to pause here for a second. I've been talking at you, and I just want to see if there are any quick questions that I can answer before I move to, the second half and last half of the presentation. Any quick burning questions? And I'm so sorry, I'm not able to see too well. So if someone does have a question, feel free to just speak up. Yeah.
Yes. So hello. My name is Rupsha. I'm one of the Global Health PhD students. I was just interested in sort of how your team came to how you were defining protest activity, because as you said, it can come in many different forms. So I was just wondering if you could sort of clarify that before continuing.
Yeah, great question. And I should have actually started with that. But the way we define protest activity is drawing on the ACLED definition of protest activity, especially given that we're using so much of their data, but we also do align with it. And I'm going to try and summarize it, and then I encourage you to also take a look at it just to cross check. But the way that we have understood this is that it is a public, and that's the key piece, a public visible demonstration that's taken by one or more individuals in response to a particular issue or with a particular goal in mind. So a protest could be, two students protesting outside the gates of their medical institution, saying that they've been harassed by the superintendent, all the way to 1,000 students in India protesting the fact that the postgraduate examination was delayed. So it can be planned, or it can be planned at sort of different levels of scale, if that makes sense. But the idea is that it is public, it is visible, and there's a demand attached to it that can be articulated by the organizers.
Any other questions?
Hi, Veena. So this is Kadirvel. I'm also a PhD student here in Global Health. So my question is related to the previous question of what are the limitation of this ACLED definition of defining the events, especially because I was going through yesterday. So they actually kind of make unique events for any 3% or more than 3% who is actually doing some protest, even it may be
Sorry,
the
apologies.
same
Yeah.
cause on different days is counted as different unique events. And this is especially related to the Kolkata rape and the murder, because in a way I was part of it. I was also protesting there, and the protest was happening for so many days, even for months. And there were some breaks, and then once again there was protest, and the Supreme Court was hearing the case, and there was protest. Then the Supreme Court says, no, please don't protest. Then once again we stopped it, and then restarted because we were not happy with the Supreme Court's decision. So it was going on for the single cause and across the country. So how, for example, because in the previous slide you have shown, it is highly blue for India, and I was kind of wondering, especially in 2024, the whole country was kind of occupied with this special protest. So how it is kind of counted for the single event?
Yeah, that's a very good question, Kadirvel. I'll just go back to that chart. I think that's an excellent question. Thank you for reminding me that it's 3 or more. I apologize. I should know that after the amount we've used this database, but just slipped my mind. So you're right that this is a piece of the analytic approach that is either a strength or a weakness, depending on how you look at it, right? In our view, it's a strength because, well, it's both, but let's start with the strengths. In our view, what the volume-based approach is telling you is that it is giving you a signal about the scale of the issue, right? It's telling you that each of these events, when you add it up, it showcases the considerable activity from this community about a particular demand, whatever that may be. Now, the downside of it, which doesn't have to be a downside depending on how you use the data, is that if it's a coordinated protest over many months, days, months, years even, how do you make sense of that? The interesting thing about ACLED is that you actually can isolate those events and you can analyze them separately. But in our view, that's an additional analysis rather than an analysis that has to be, accounted for necessarily within these, early initial analyses. And the reason is because if we started to, go through these thousands and thousands of protests and try and isolate them into these different clusters, I think that would be answering a slightly different question in our view. It would be talking about more protest dynamics rather than these kind of descriptive statistics of volume and who is organizing it and where are they organizing it. So the point is taken about that being a potential weakness, that it's not accounting for those coordinated strategies, but that is an area of further exploration that we are keen to do actually in our upcoming studies, and invite anyone interested in this to kind of join us in that actually.
So there is a follow-up question related to the demands, how you are assigning the demands, especially with the ACLED database, because at least except this Kolkata murder or maybe the NEET PG examination in India, so the remaining protests which happens, especially in my institute, every fortnight there will be a protest. And it is always like not a single demand, it will be a list of demands. And there will be like maybe they get a solution for one demand, but remaining demands will be there in the demands, and then it will be like once again a protest. So how the demand is kind of assigned, or the reason for the protest is assigned in case of there is a multiple demand.
Great question. Great question. So you're right that so obviously from your experience, you've conveyed it so well that there are usually multiple issues that are involved. So the good thing about ACLED, as far as we understand it, or as far as we have used it, is that they are very clear about identifying all those different issues when they describe the event. So it will say in the summary that you're given in the event that, okay, protesters are demanding improvements to the hostel. They're demanding improvements to unpaid stipends. So they're demanding the release of unpaid stipends. They're demanding the removal of a principal. It'll say in the same event summary, these are the 3 protests. And so then we count we count all of that within the analysis to say that, okay, there will obviously be then more than 118, but we kind of make sure that we account for each of them when we're looking at the final sort of tally. I hope that makes sense.
Yeah, thank you.
Because, and I should also just say, it would be very difficult for us to assign a primary issue. It's hard, we don't know that from the event data. But what we can do at a minimum is account for everything that is said in the event summary. Okay. So let me move on, just so that we have enough time for questions at the end also. And I'm going to maybe do this next part a little bit faster, because I want to leave about 10, 15 minutes for questions. But I think as this discussion is highlighted, protests from a database are only going to tell us a sliver of the story, right? Like, it's not going to be able to tell us the depth of the issues involved. It's not going to be able to tell us, as we've talked about in the previous slide, how protest fits within a broader set of advocacy strategies, whether that is direct communication with the leadership or other types of social media pressure, other types of public engagement, like, for example, with the media. It doesn't really tell us about how these things fit together. And it doesn't tell us about institutional context and political context. So what we decided to do through the same SHIRK project was to do a series of case studies of protests in Canada, the US, and India. On the surface of it, these are three very different countries, but we actually think there's some good similarities in terms of their federal structure, the fact that the subnational unit, the state or the province, is the responsible authority for health service delivery. And we also thought it'd be just very interesting to look at different countries with different levels of public sector involvement, whether it's financing or delivery. So some of the examples that came out of our previous work were examples around contractual nurses who are contracted to the state health department in Karnataka in southern India. We saw an example of nurses in Alberta who were demanding that a proposal that would cut their wages by 3% be revoked. And we also saw a similar example in Minnesota where nurses were protesting the demise of a nurse-to-patient ratio program. And so what we decided to do was to focus on the nursing profession and to focus on these three cases and then zoom out a bit and try and understand how protest fits within the larger picture of how these unions and associations are working. So maybe just to kind of set the stage a little bit here, fewer studies have examined how unions and associations have navigated changing contexts. One thing just to say here is that in global health, we talk very often about health workforce issues and human resources for health, but there's often very little politicizing of those issues, right? Like we don't look at how labor and labor rights fit into those conversations, even though as the previous speaker said, this is a daily, weekly occurrence that consumes actually many policymakers, is dealing with various unions and associations. And it's also a question of rights. It's a question of, if the health workforce is as important as all our policy documents say they are, then why are we not taking a closer look at how they are organized and how they are advocating? So that's kind of the overarching context, is that we're also trying to address a broader gap we feel in the study of unions and associations in global health. So there are fewer studies that have looked at how unions and associations have navigated contexts like COVID-19, growing privatization and corporatization, growing reliance on contractual labor, key issue in Canada, issues like health workforce migration. There is some more research that's happening on domestic policy actors like the hospital industry, but we don't see enough about labor's role in healthcare reform. And this is quite interesting also because we do see more attention to the labor movement more broadly in response to corporatization. So let's think about the unionizing efforts at Amazon and Starbucks. Mind you, this is pre-Trump, so we don't know how this is going to look in the next couple of years. I suspect not good, seeing the changes he's made to the National Labor Relations Board. So the research questions that we have been exploring in this study are: how do nursing unions and associations react to and influence policies promoting privatization, corporatization, and contractual work? So we're kind of narrowing in on this piece. How do political environments shape how unions and associations are engaging on policy issues? And how do internal organizational factors shape and influence the advocacy approaches of health workers and unions? So what is happening within the association, within the union, that's shaping how they are engaging externally? And can we compare these patterns across Canada, the US, and India? Are these just three very different contexts, or can we pull some themes out that can say something more broadly about health workforce politics? I won't go into methods just for the interest of time, but I'm happy to chat it through in the Q&A. I know there are many doctoral students, so you might be interested in discussing these further. But we used interviews, observation, document reviews, and we can chat that through in the Q&A if you'd like. We have an emerging analytic framework to help us make sense of this data that focuses on institutional context, so political regime, political context, labor relations. We have a focus on organizing, so how organized is the union or the association? What's their power? What's the power of nursing within the wider labor picture? What kind of bargaining tools do they have? Can they engage in negotiations over their contracts? And what kind of dispute resolution do they have? And then the kind of bottom quadrants are strategies, tactics, and framings. This is drawing from some of the work from Weibel and Heikkila, and also looking at feedback. And this is really key for us, right? Like we're trying to understand what does protest tell us about outputs and outcomes. So the emerging argument and very early findings, I just need to kind of caveat that, is to say that we think that this is the following kind of pattern that's emerging. The political economy of healthcare and the policy priorities of unions and associations are obviously interconnected. As governments and employers turn to more austerity-driven approaches, the unions and associations become these accountability checks. They take varying aim at structural problems, but they do serve as an accountability check to these wider structural shifts. The nature of political economy in a particular context can give rise to new organizations. So like for the example that we're going to talk about, in Karnataka, contractual workers have their own association because of how much that they are used in the government system. And there are broader questions about, how unions and associations across contexts learn from each other. The bargaining power and ability to achieve these outcomes is influenced by, labor organizing and that framework for the profession, and also the extent of private involvement in the system. And this is the idea that we're testing out. Would love to get your feedback. In at least Canada and the US, unions and associations are leaning into more progressive political projects, but the unions are really caught navigating this shift because their membership is very ideologically divided. So let's talk through some of those examples. United Nurses of Alberta, one of the examples that I mentioned, very powerful union. The protest we looked at was about rolling back their wages, and became a sort of steady escalation in tension with the conservative UCP government and then in the UNA. And the UNA is considered very powerful, strongly aligned with the NDP in that province, even though about 30% of their members probably vote for the UCP. But they say, we're non-partisan, but we're political. What's been interesting with the UNA is that there is this fragmentation of healthcare in the province, as many of you may know about. And the rising polarization within the province has created this tightrope for the union where they are pushing against reductions in public investment in health and all these ways to destabilize the unions, but they fear that they're worried that they're going to be seen as going too far to the left. And so that includes also, how they use strike action. So they've been slowly ratcheting up their advocacy during contract bargaining that's going on right now. But they're worried about, should we in fact pull that strike lever, given that conservative locals are maybe less enthused about that idea. So it's an interesting example that I would encourage you all to keep your eye on. Right now, they've been kind of protesting and they're in mediation right now, but they had a day which recognized the 1988 strike that happened in Alberta, a day of action. So there's some signals that this may be the direction they're going in. Minnesota Nurses Association, I won't spend much time on this example, just to say this was a case that happened over the last few years where nurses were really pushing for improved staffing ratios. And Mayo Clinic, which is the most powerful hospital in the state, called on Governor Tim Walz, somebody who we were very familiar with last year during the election. And they threatened to withhold billions of dollars in the state. And Walz ultimately capitulated, and the bill was killed. And so the Minnesota Nurses Association has really now reframed their fight in terms of pushing for, staffing regulation in terms of a broader agenda around anti-corporatization of healthcare. Now, why is that an issue? The issue is that they still stuck with this challenge of how do you manage ideological diversity within the union, say around reproductive justice, when on the right, they have kind of pulled together socially conservative issues and conservative policy around health. So that creates a tension for the union. There's also some questions about partisan politics. So the Republicans are actually saying, yes, we do support you, but we are concerned about your positions on progressive issues like reproductive justice. The Democrats are interestingly saying, hey, you're not strategic enough in how you work with physicians and the hospital industry and other corporate actors. And then the final case is contractual nursing in Karnataka. And I know I'm running out of time, but maybe I'll just say that there are really, really major inequities with how contractual nurses are treated in the government system. So as one of the respondents for our colleagues who spoke to our colleagues said that it is literally slavery in terms of how they're treated with very little job security, and notes that it's a difference between a child you give birth to and a child you adopt. And you can see in this picture over here that nursing associations are very, very fragmented, right? There are lots of different groups and they don't necessarily band together when it comes to advocating for becoming permanent staff, increasing their pay, having better leave policy, including for parental leave. They've had, through the use of protest and other tools, they've had some favorable outcomes. So they are being given better leave policy, they are being given better salaries, but they have also been told that, no, you will not be regularized, we will remove you from the service. And the state government's actually saying, hey, this is not our problem, this is the central government's problem. So they're kind of making modest gains. So let me kind of skip to key takeaways. I know we're running out of time. Just to wrap up a few of these things. So health workers are increasingly using protest as a way to visibilize their discontent. Protest demands are often reflecting structural concerns, but they also do reflect ideological shifts. Protest demands are signals of structural position and agency and power. And looking at particular countries and looking at particular groups tells us a bit more. And kind of then moving in deeper into unions and associations, we saw 3 very different outcomes between Alberta, Minnesota, and Karnataka. Alberta nurses are able to gain some modest, or I should say they can secure some modest gains despite the anti-union approach of the government. Minnesota, they were not able to do it despite strong mobilization. And in Karnataka, very modest outcomes. So the neoliberal project, I think this is where I'll wrap it up, is creating these conditions that are destabilizing unions externally and from within. And maybe that's where I think future directions of research need to go, expanding our focus to other types of workers, other geographies, different factors, looking at health politics beyond rights, of course, inclusive of rights, but beyond that, addressing different types of public policy and really bringing in labor framework. So I want to acknowledge my colleagues from UBC, from Columbia, Azim Premji, and also Shirk Funding, and look forward to your questions. Thank you.
Thank you so much, Veena. That was wonderful. I feel like there are going to be many burning follow-up questions. So without further ado, who wants to go first?
And Kerry, should I take off the slide share? Would that be better?
I guess so. Then we can see also if there's people online with questions too.
Okay.
Great. So we'll start with in the room. I mean, one of my early reflections is just how complex this space is. And I'm always struck by this competing this sort of tension in my own heart and mind around my deep support for labor rights and unions and this immediate affinity to those who are striking. held beside my knowledge that when Tommy Douglas was trying to introduce Medicare in Canada, the biggest opposition was the doctor's strike in Saskatchewan. And as we saw, the Indian Medical Association often has aligned with sort of anti-regulatory policies that speak to, trying to hold a system that quite privileges doctors. So, and then to bring up the nurses who are, fighting for dignity and wages, and also fighting against vaccine mandates, against lockdowns, and sort of this deep complexity that you have to make sense of in this space. That I just, it's incredible how you've navigated it.
Yeah.
Does anybody want to go ahead? Yeah.
Maybe I can just respond to that, Kerry, just to say that it feels as though, we are trying to sort of check our own biases when we're doing this work constantly. Because when we started this project, it was very much with this sort of approach of we need to verbalize or articulate, what are all the struggles that health workers are going through. And that is true, but there is a deeper picture to it, as you've said. So I think actually taking a step back has been more useful, because it actually tells us more about the broader shifts, not just in the healthcare system, but in society more broadly. And health workers are a part of that, right? Like they reflect the tensions in society just as much as any other profession will. So I think that is my kind of take on all of this at this point, is that we do have to, as qualitative researchers, we know that we come in with our biases, but in this case, it is helpful to kind of take a little bit more of a neutral stand when doing this work.
Mm-hmm. Absolutely. And to really deeply hear them, when they do protest against things that, my bias says, why are you protesting that? Like, to listen to the fears that they hold and the reasons driving them. So who can I? Oh, Mary, yes, please go ahead.
Hey, well, thank you, Veena, for that wonderful presentation. I actually had a master's student who looked at women physicians and, their sort of conditions during COVID in India. And so I was wondering, either from the database you were looking at CLED, or your own work, is there any sort of coming together of women nurses and women physicians to sort of mobilize together?
That's a really interesting question. I don't know the answer to the coalition part of that, in terms of, do we see, for example, nurses and doctors coming together to protest events that have happened, such as the one that we were discussing, that I think one of our colleagues in the room has direct experience in being part of those protests. I'm not sure to the extent how those coalitions have come together in the case of violence. What is clear, though, is that they are protesting in their professional groups when violence happens to those groups. We see examples of that repeatedly in the database. If violent attacks happen to a nurse, a doctor, a paramedic, a trainee, I think this is one of the pieces probably that I forgot to mention in the slides themselves, but protest is a form of accountability when there are few avenues otherwise. And so that, I think, is the key piece here. And ideally, we'd love to see more, coalition across cadres. One of the maybe more concerning findings from the trainees analyses was that there is a lot of protest organizing that's happening within professional groups and not across. And I think, and you see the dominance of physicians in that group. So we have to kind of try and find ways to understand why that professional siloing is happening. Yeah.
Right, right. Because of course, women often bore the heaviest burden during COVID. It's not just healthcare workers, but within their families and so on. But, okay, thank you so much.
Thank you, Mary. Yes. Please go ahead and introduce yourself.
Thank you. Thank you so much, Veena. Can you hear me?
Thank you. Yeah.
All right. Thank you so much for this great presentation. looking at most of the issues that are responsible for the protests, like you mentioned, issues of remuneration, issues of quality of services and things like that. What are your thoughts regarding our health system governance and financing at the moment? Is this something that we need to look more into as a preventive measure towards reducing the frequency of these protests? I know there are extraneous factors like the socioeconomic conditions, and we are likely to see more protests, given what we're seeing around us now in terms of socioeconomic conditions. What are your thoughts with this? I mean, is this something we can fix only by looking at our health system governance and financing systems, HR policies within the health sector? Or do we need to engage others outside the health sector, for example? How should we be looking at this?
Yeah, that's an excellent question. You all are giving me really good ideas about, how to kind of also peel back a bit and think through, what are some of the implications for the system. I think you're absolutely right that this does come down to governance and on multiple different levels. I think one of the reasons we see so much frequency, as I was mentioning earlier, is the fact that there are few formal platforms for conflict resolution and dispute resolution and negotiation within our health systems at the moment, particularly for cadres and professions that are not physicians, right? They very often do not have seats at the table when deciding policy, and also just from a labor standpoint. I also just want to also be clear that I'm not saying that the unions and associations aren't without politics themselves. So just to say that what issues come to the attention of decision makers and what do not and what doesn't is also a question that we have to think through. So, for example, with nurses, the fact that so many nursing unions in India are led by men makes you think, okay, are they actually conveying the issues around sexual violence to decision makers? So we'll put a pin in that part for a moment, but just kind of going back to the earlier part, that there is a major gap currently in our governance structures in terms of voice and representation for the majority of professions. And even within the medical profession, I think students and junior doctors are not given that same kind of platform. Why this matters is it matters for all the reasons you described. These are the people who are doing the labor of the system, and they're not given a voice in any of these decisions. So it's going to eventually explode into a situation where you do have to take to the streets to say what's on your mind, right? That's one version of it, and we have to kind of think through better structures, better platforms to have that kind of discussion. But then let's also think about the examples where, like Kerry brought up the Indian Medical Association and protests against Right to Health Acts, which are complicated. I know, like it's not a straightforward policy debate, but or even the Indian Medical Association's pushback against regulation of the private health sector. One of the challenges there is that we don't have consistent negotiation and debate structures for these kinds of major healthcare reforms. It feels as though, the IMA uses protest as a way to almost box the government into taking their position at the expense of everybody else's. And so we need to have more inclusive, more productive avenues to debate these matters of enormous consequence to the people. And not have protest be used as a way to kind of push the government into one particular avenue. So on both counts, I think we need better systems of governance, but maybe for different reasons. Yeah.
Thank you so much, Veena. That was absolutely wonderful. I think we promised we wouldn't take you beyond the hour, and we'll respect your time. Let's have a round of applause to thank Veena.
Thanks for the invitation. Thanks for the questions, and have a great rest of your day.
You too. Thank you, Veena.